Yeah, the optic nerve head in glaucoma, that is the topic given to me in today's clinical scenario. So we have about 1.2 million axons, which is divided by septa, and there are about 1,000 fascicles. That's what we are going to look into deeper. So these are the contents that I'll be kind of focusing on in this 5 minutes talk. So we have multiple ways how we can do the examination of the fundus, but I prefer only these two, like slit lamp as well as the fundus photography. But I want you to really appreciate how big is going to be the fundus photography in comparison to what we see in our, even if it is dilated fundus examination. So this is what is the area of interest for us. And then many of us do draw the picture in the case sheets, but now as the EMR has come up, that most of the time we are not drawing it. So there are different disc sizes varying from less than 1.5 and it's a little slow here. Small, medium, and the large disc. It has its own importance. Let's see. And there are different shapes, especially the PS-shaped ones is the commonly mistaken for an inferior notch, and then we diagnose it as glaucoma, and then we come up with all the treatment modalities. And then there are different, many patients will have a asymmetry, and then again we have the confusion of whether the patient has a glaucoma or it is normal. So this is the area of interest as we have discussed. Looking at the disc size, how many of us really measure the disc size? Most of us we don't. It is just an assumption that we think that is a small disc or a moderate or large disc, but ideally if you can go with your BMO based disc margin, then we have the disc size accurately measured. You can see the small disc, the BMO area is about 1.6, that is a normal size, in comparison to the disc which is about 3.38, that is a large disc. So why is this important for us? The true disc margin has a lot of clinical relevance because this is how we see in our 90D. This is the clinical disc margin. We look at the inner edge of the scleral ring and then we say that is a disc margin. But when we do it with the OCT, the disc margin is completely different. That is what we pick up as a Brooks membrane opening, BMO opening disc margin. See the difference between these two. The green one is the clinically assessed and the red one is the OCT based. Because in the OCT based, the blood vessels and the retinal nerve fiber cannot penetrate the Brooks membrane opening. That is the main reason we say that is the true disc margin. We will discuss that when we have some time, and it is correlated very well with the functional visual field changes. So we can discuss that over when we have the discussion time. Looking at the small disc and the large disc, what is the clinical relevance? Large disc will have a larger circumference, so the nerve fiber can be spread out, the axons can be spread out. In a small disc, it is all crowded. When you really clinically look at in your OCT, see the top, that is called as a micropapillae, that is a small disc. With the crowding, it lies in the top of the line. In the green zone, it lies in the top. And when it is the macropapillae, that is a large disc, will be lying in the bottom of the green zone. So you should not take that as abnormal. If the micropapillae zone has come down in the bottom, that means again the patient still has a glaucoma. If the macropapillae has gone up, probably the patient has a disc edema. So you'll have to be a little careful on reading your OCT pictures. Looking at the RNFL layer defects, what we really see is many times we may have the confusion of whether that is true glaucomatous or non-glaucomatous defects, which may again arise from the disc margin. So let's see the glaucomatous defects. Many times we may not be able to really pick up, but once you can use the red free, then you can really pick up the glaucomatous defects, RNFL loss. See this very, very tiny defect, that is a slit defects. The arrow shows there, and then you can see the defect is becoming larger as the cup increases in size. And you can see here what is the pattern that you need to observe is look at the inferior RNFL loss, the first picture on the top. It is more closer to the papillomacular bundle. Once it is more closer to the papillomacular bundle, that is most likely a NTG pattern that we need to understand. And you see the second and third picture, it is not very close, it is a little away from that. You can see that, and it is kind of progressing. We need to understand that. Then looking at the total RNFL loss, you can see as though it appears very clean. and all the blood vessels will appear to be more brighter than what it is normally seen. You can see the healthy RNFL versus the total RNFL loss, both superior and inferior. And looking at the RNFL loss, you see at the top again, there are the peripheral RNFL defects. The peripheral RNFL defects are very important again. It could indicate patient may be having multiple sclerosis, thyroid disorders, Alzheimer's, and all the B12 deficiencies, high homocysteine levels, all this you can really pick up from that. And you see the right hand side picture that typically has the glaucomatous in origin with the inferior RNFL loss. And looking at the disc hemorrhage, you see the disc hemorrhage of first picture on the left. You can see the RNFL loss superiorly. And you see the second picture, there is a same kind of a splinter hemorrhage, but there is no RNFL loss. It could be of various other reasons. And see the progression of the disc hemorrhage. Once it disappears, it leaves out a RNFL loss. Please pick up that. If you can pick up that, then that is very typical of glaucomatous in origin. And looking at this, there are two different types of optic pits. One is the congenital optic pit, another one is the acquired optic pit. The congenital optic pit, you can see that it leaves out a large area of inferior RNFL loss. Usually it is typically only in the inferior area. The congenital optic pits are mostly in the temporal side, leaving out a small area of defects also. So these are the optic pits. And looking at the RNFL loss, you might see that the RNFL loss, you can see the superior RNFL loss in a large area. And you see again one more RNFL loss here also. Both these are patients who had a stroke. It is not from the glaucomatous origin, but you see the cup, absolutely there is no cup. This is a fresh patient of about 4 weeks. It's not fresh, means 4 weeks, at least 4 to 6 weeks it takes time for the RNFL defect to be formed. And you see how it is above. It is not at the glaucoma zone. So you have to pick it up. So there are so many examples we can show. As Devan has given me only 5 minutes, I'm just showing some clinically relevant pictures for you to take home some message. Thank you.